Relating to snapping hip syndrome, this is not labral pathology, correct? Right? If you look ahead, you know it's not, right? It's extra-articular. Okay, so when you're doing your exam, it's important to be able to discern whether or not the snapping, clicking, what have you, is coming from an intra-articular source or extra-articular. So today, right now, we're discussing the extra-articular. Okay? Wow. This doesn't want to work. The Army always decides to do pushes, right? Updates. Never. There we go. You see it move up. Okay. So by definition, a snapping cessation has a tendons glide around the hip over bony prominences. Okay, so that's what it is. So is it sometimes called snapping hip friction syndrome? Yes. Is it called hip friction syndrome? Yes. It has a bunch of different terms, but they all basically mean the same thing. Okay. So when we talk about snapping hip syndrome, there's two different classifications that we have to get used to using when it comes to discerning what tendon, what area we're talking about. Okay. Number one there, as it says, is the IT band at the greater trochanter. Okay, so we know the greater trochanter is lateral on an AP view, correct? So if it's lateral on an AP view, where are they going to have pain? Lateral hip. Okay, so when it comes to hip pain, I want you guys to get very comfortable asking your patient, is your pain anterior, lateral, or posterior? Okay, and then you're always going to ask them to point with one finger, correct? Hopefully it's not their middle finger. Okay. But IT band and greater trochanter. Okay, so we agree that that's on the external side of the hip, right? So what kind of snapping do you get? External snapping. Okay, so there we go. We put our anatomy together and we put together our symptoms and said, okay, this is coming from an external source. Okay, meaning external to the medial, right? So ilium psoas at the pelvis. So we know that we have a psoas site, correct? So ilium psoas at the pelvis basically means it's more medial, correct? Okay, more central, more medial. So that's how we discern that. So that snapping cessation could be internal snapping at the iliopectineal. Okay, and then here we go again with labral tears, right? That's internal snapping, but what that means by internal snapping in this case is that it's intra-articular. Does that make sense? Okay, so the iliopectineal eminence, is that intra-articular? Negative. Okay, so don't get confused by that terminology. Okay, this is a nice little review of your anatomy again. Okay, kind of discern some of the different anatomical features that you're concerned about with this pathology. And it also goes through the iliotibial band and tells you that the iliotibial band is lateral to the thigh, the hip, correct? And extends down past the knee and inserts at blank tubercle. What tubercle is that? Gerdy's, correct? Gerdy's tubercle, right? So that's why that's, when you're talking about Gerdy's tubercle, that's lateral proximal tibia. Make sense? Okay, so where might they have symptoms if they have IT band tendonitis? Anywhere throughout there, plus or minus the snapping. Does that make sense? So you can have IT band pathology without necessarily having that snapping. Good to go? We're all tracking on that? Okay, so if you're not familiar with this anatomy, again, now's the time to familiarize yourself. Okay, because we're talking about gluteus medius, minimus, and the IT band, right? And we'll talk about a condition here in a second where all three of those things can be affected. But for right now, we're just talking about the IT band. Okay? So when are they going to have clinical symptoms? What are they going to report? They're going to report that they have that snapping, that pain, with walking and rotation of the hip. Okay? If it's IT band or external snapping, then they'll localize it to the greater trochanteric region, so lateral hip. Okay? So they'll point with one finger to the greater trochanter. Okay? All right. So, but sometimes they can have no pain. So that's confusing. If it's snapping, don't they have to have pain? Not necessarily. Right? So IT band, a lot of times, some patients will say, hey, I can make my IT band snap. Watch this. Right? And they don't have pain. But when are people going to present when they have pain? Nobody wants to come show you their party tricks. Okay? Some people do it. But ilium psoas, right? So ilium psoas is going to be different. That's when they do hip extension from flexion, i.e. rising from a chair. Okay? So if I ask Lieutenant Bishop to stand up from his seated position, at Easter. Then he'll report that he has that snapping internally. He'll point to the ilioepictylial eminence. Everybody think, right? You don't have to point, right? But think about where the ilioepictylial eminence is, right? It's in there, right? So it's deep in there, right? So, right, they report ilioepictylial eminence type snapping and pain as being groin pain. Yes. That's why groin pain is a very vague diagnosis, or a very vague symptom, I should say. Groin pain is not a diagnosis. But again, here it says no pain, right? But that's just because some people just have this. Okay, if they have weak IT bands, they have weak iliopsoas muscles, right? And they're not strong and tight, if you will, and robust, right? Good muscle tone, then they may have looseness there, and therefore they'll have some snapping. Does that make sense? But how does this slide differentiate labral tears? Pain. Okay, I will hold true to this for testing purposes. Okay, does that make sense? Because I've already explained to you that some people don't have pain. Oh, do people come see you when they're painless? No, right? They go to the ER, but I'm just saying, right? So, but they do have what? Mechanical symptoms. So every time I've discussed labral tears, I've always told you labral tears go with mechanical symptoms. Okay? Again, they have that snapping, clicking, popping, painful, okay, especially when going into deep squatting or when they're crossing their legs or whatever activity does that. Okay? Make sense? Are we all on the same page about this? There it tells you the iliopsoas again to review the anatomy. It's localized to what? The inguinal line. We already decided and defined where the inguinal line is, correct? So that's that distance between the ASIS and the ilioepictylial eminence. Okay? So they can have pain anywhere in there, really, but it's usually going to be internal, so it's going to be more medial. Good to go? Okay. So physical exam-wise, we're really going to get into this stuff with physical exams. Okay? So we know that we probably already practiced, what, the Ober's test? You guys kind of know what that is? You're probably doing it wrong. Okay? So we'll get better at that. Okay? Because, you know, most people honestly have tight IT bands, right? They work on the anterior, posterior activities, but they don't work on the lateral activities to strengthen that IT band and also to make it nice and flexible. And as we get older, right, more mature, more seasoned, our IT band naturally gets tighter. Okay? But the snapping at the greater trochanter, right, you're going to do an over test for a tight IT band TFL. What is TFL? Fascia, right? I like the way you said that. So it's a tensor fascia lata. Okay. So basically, that is another component of that lateral IT band structure. Okay. Would you agree that the IT band, while it does help moderately with flexion, right, and extension of the thigh, the leg, that it mainly helps with abduction of the hip. Right? So what is what are you testing with over? You're putting him in abduction and then letting him go and see how far down the leg goes to gauge how much tightness of the IT band they have. That makes sense, correct? Okay? All right? Good to go. All right, so again, we'll practice that in the lab, and we'll do it correctly. Okay? Then you have psoas, you have snapping at the inguinal line again when moving from hip flexion to extension. Okay, so are you going to ask Mr. Bishop to sit down and get up, sit down and get up, sit down and get up? He'll do it, right? As he demonstrated. Thank you, sir. He's too excited. All right, he'll do it. Well, basically, you can put the patient supine on the table and you can flex and extend their hip. Does that make sense? Can you also rotate their leg in and out, right? Medial and lateral, and see if that affects it? Yes, you can. There are other tests for this that we don't teach you. Want to learn those, I'm happy to teach those to you, okay? Okay. But I'm just telling you, you don't have to have the patient, you know, like he's standing guard at post, sitting down, standing up, sitting down, standing up. That's just awkward, okay? So, and then labrum, again, if we get back to that concept, they can have limited internal rotation, okay? If they have a large enough and significant labral tear, will that cause a mechanical block to motion? Yes. Right? The labrum tears, flips, and gets lodged in there, and then the femoral head can't glide, and he has to tabulate like it normally does. Does Does that concept make sense? Have you guys ever heard the term mechanical block to motion yet? No? Okay. Well, you'll hear that a lot in orthopedics because those, with certain fracture patterns, we want to see if they have a mechanical block to motion. And this is an example of mechanical block to motion because, again, the labrum is torn, flipped, and engaged, right, and blocking the femoral head from rotating in the acetabulum. So that is a mechanical block to motion in this case. Does that make sense? So if you went out there in phase 2 and you see that term, right, or your preceptor looks at you and says, hey, Mr. Griffin, does that patient have a mechanical block to motion? All they're asking you is, when you took them through range of motion, was it limited and you had a hard stop, right? You weren't able to completely internally rotate. You weren't able to completely extend the elbow, right? We'll get to that. We'll talk about radial head fractures. Okay, things like that. So that's all they're asking you. Good to go? So diagnostic-wise, again, we kind of covered this already, but radiographs, AP pelvis, and lateral hip, okay? I did highlight yesterday that when it comes to pelvic films versus hip films versus SI joint films versus et cetera, there's a lot of films you can order, okay? Getting back to the concept we talked about yesterday, if somebody presents and you think they have snapping hip syndrome, right, but you're concerned about proximal femur pathology as well, not only are you going to get an AP pelvis, a hip view, but you might also get a femur view. Because are the femur views better at looking at the femoral neck? Yes. Okay, the answer is always yes, right? CT arthrogram if mechanical symptoms are present, okay, and basically the CT arthrogram, think about it this way. So if you have mechanical symptoms, but you're not worried about soft tissue pathology, you're worried about little pieces of bone floating in that joint, right, in and around, and feeling like those are causing the mechanical symptoms, or those are causing the mechanical block to motion, because it's possible, if those little pieces of bone, which I call chiclets, you guys have heard me say that earlier, right? Those chiclets are floating in there, and they're causing a block, we'll see them better in the CT scan. And then by doing the arthrogram, will we get a better look at the labrum as well? Yes. Okay, so that's kind of a twofer, if you will. Well, what is the mainstay of diagnosis for this kind of snapping hip syndrome? Well, we discussed terms like IT band, we discussed terms like tensor fasciculata, Brady's tubercle, we discussed what? Iliopsoas. So those are all soft tissue things, correct? So, I mean, MRI is going to be the best thing for confirming our diagnosis. So that is a confirmatory test, which is in bold gold. Okay? Anytime you have a concern for a labral tear, you're going to get the MRI. But you're not just going to get an MRI, correct? You're going to get an MRI arthrogram. So they're going to inject that dye, they're going to turn the machine on, they're going to see what they see. Okay? And then also if you want to evaluate for other injuries. Okay? If you are palpating or in and around the abdomen and you're concerned about other pathologies, this is a good way to discern, is this truly iliopsoas or is it something else? Okay? Make sense? Everybody sees that labral tear there, correct? You can see it clear as day. Nice black stripe there, and then now you got a white line in there where that black consistency is broken. You see it? You think this is hard to see if you're not used to looking at MRI orthograms? Absolutely 100%. Okay? I'm not testing that. If it's a picture with a circle, an arrow, whatever, it's probably a labral tear, right? So, but you just have to understand that the arthrogram, that's what it's used for. It's used to see if there's any kind of break in that normal, smooth labrum, right? And you can say, okay, that looks like a labral tear. Okay, what kind of labral tear is this? Anybody know? I don't either. Why? Because this is one view. This is useless. Okay, I know where it is here, right? So that looks inferior to me, right? Because you're talking about relation to the hip. But is it anterior or posterior? How do you know that from this view? You don't. You need a sagittal, right? Okay. So again, all that learning in radiology you did, that was great. But that has no use here because everything is dynamic. We got to look at things in multiple planes and really get a sense. Are we talking about superior, inferior? And then rotate and say, are we talking about anterior, posterior? What percentage of the labrum is torn, et cetera, et cetera. You need multiple views. Good to go? So that's not a fair testing question for my class. Other people can do it along. All right, adverse outcomes of disease. Snapping hip sounds annoying, doesn't it? All right, does anybody here have it? Based on the numbers, somebody does. Okay? Yeah? You got that too? Yeah, okay. All right, excellent. She's our go-to patient. Okay, I'm joking. But anyways, so yeah, it's just something that people have, right? And sometimes you're just built like that. Like my kid says that all the time. Dad, I'm not built like that, right? It's just, that's what it is. Is it painful though? No, right? So she does nothing about it. She ignores it, right? So it's just something that can happen. But then if they go on to have pain, they can have chronic pain. Hip bursitis. Here we go. How do they get bursitis? Is there a greater trochanter? Is there a bursa there between the skin, tendon, and bone? Yes. So we'll talk about greater trochanteric bursitis later. But they can have chronic bursitis, and that can be quite troublesome. So they will literally point to their greater trochanter and say, this is where 90% of my pain is, and then 10% of my pain is more distal in the IT band. I taught you guys how to do that, right? If someone says they have pain in multiple places, you break it down into percentage, right? 100 to 100, so everything, they have to break it down to 80-20, 50-50, 60-40, right? If they get to 200%, that doesn't make sense, okay? So weakness in the hip or leg, well, we know about this, right? If they have iliopsoas weakness, they can have decreased function, correct? So if it's long-standing and or associated with a tendon tear, they could have potential weakness. Make sense? And again, this is muscular weakness, strength, not neurologic. Okay. Unoperative treatment. Okay. If it's not painful, you say, you know what, you're going to be just fine. Okay. You reassure them. You give them education. Right. You give them education. Right. Very simple. You give them some hip exercises. It's in here. Right. Hip strengthening exercises. Do you think that hip strengthening exercises involve the knee? Yes, because IT band spans the knee, correct? All right, so we know this, right? So this is my moment to tell you something. Hip pain can be knee pain can be hip pain can be knee pain, which is also ankle pain. It's all the above. So do you think when you're doing a hip complaint, as a bless you again? Let's wait for it. Nothing? Okay. All right. Oh, she did. I was waiting for another sneeze. I didn't want to say thank you 4 times. So when we're talking about this, do you think when you're doing hip exams, you also got to do a knee exam? Oh yeah, right? So if you document only a hip exam, that's wrong. Good to go? So that's why in lower extremity, we teach you hip, knee, and then you move on to more lower extremity, foot and ankle stuff too. Okay? Good to go? All right. So, but if they do have pain, and again, this is a number 1 and number 2. So how are you going to study? You're going to study like this. Okay? So number 2, you do the NSAIDs, the rice, activity modifications, and physical therapy. Okay? So if they go on to have chronic pain, okay, like we discussed, or they have significant weakness and they can't do physical therapy, because the definition of insanity is sending somebody to physical therapy, telling them they have to do physical therapy, but they can't do anything because they have significant pain and or weakness. Right? You can consider doing an injection. Okay? And that, again, that's a fluoroscopic guided hip steroid injection. Okay? And again, that can be diagnostic and therapeutic. Right? When you guys are out there in phase 2, you'll also realize that you can do injections into the IT band. But you must do it carefully, right? And precisely, because if you do it wrong, what happens? Ruptures. Right? That's a big deal. Okay? So this is talking more again. Let's say they have internal snapping, right? And they want to inject in and around that area. Okay? You can do a fluoroscopic guided. Okay? And if you're concerned about labral pathology, right, you may do this. We discussed this yesterday. And then if it doesn't improve, what's the other option? Do the Lord's work, right? Go in there, do operative hip arthroscopy. Okay? We talked about arthroscopy. We understand what that is. Anybody who's had hip arthroscopy knows that the table that we use for hip arthroscopy is very special, right? It looks like you're going skiing. You remember it? Right? So basically, it's a table that's split. The leg is on 2 different branches. You have like what looks like a ski boot on. And while you're in surgery, your lower parts are very exposed, by the way, right? You don't remember that part. Okay. So, but basically, we can take one leg and put it like this. We can rotate it in. We can rotate it out. Right? Because that what we're doing, I told you guys already, explained to you that the labrum is 360 degrees, correct? But sometimes to do certain things, we got to rotate the leg. So we got to be able to do that intraoperatively. The PA is not there holding the leg, rotating it. Unless you do something wrong and you make somebody mad. The table's doing the work for you, okay? So basically what I'm trying to get at is if you're signing somebody up to go get a consult with orthopedics for hip arthroscopy, just understand there's a lot that goes into it, okay? So don't promise them what? They're gonna be pain-free, correct? Never do that, I'll find you. And then also tell them there's a lot involved with that, so it's better if the surgeon discusses that with you, okay? Good to go? So does this sound like maybe that's a surgery, hip arthroscopy, that's only done in certain places? Because it required a specialized table? Yes. So when I was stationed overseas, I had to send them a tripler. Okay, so you'll get used to figuring out who does what, and where they do certain things. Okay, because you will be dealing with hip pain, I promise you. You will be dealing with FAI. You will be dealing with hip labral tears. I told you already, everybody over 35 has some degree of labral pathology, okay? There's been studies done, okay? Good to go, enough on that. Any questions about my explanation of that? No? Okay, awesome. So outcomes of treatment. So you get treatment, right? But again, I told you, they can still have persistent pain, okay? They can have nerve damage. What nerve? Lateral, something, oral, something. Yeah, femoral cutaneous nerve. Okay, so you might want to know that, right? Muscle weakness or atrophy. So, you know, I don't want to put anybody on blast, but I worked for one of four at the time, a hip arthroscopist in the military, not the Army, not the military, right? When we put him in the hospital, we did the surgery, right? We put him on the floor, we get ready to discharge him. We send him home with what's called a continuous passive motion machine to get them moving, but no strenuous impact activity, okay? So if somebody who's a highly active person now undergoes this surgery, right? Motion is key, right? Stiffness is the enemy, but sometimes they can get some weakness and they can get some atrophy because of disuse. Everybody understands that term disuse? They're not using it, okay? There we go. Infection, well, that's always true, right? Especially with that technique. And maybe they get labral tear surgery, right? Some kind of labral tear, some kind of FAI surgery, right? And then they go on to continue running, continue jumping. Do you think that arthritis is going to continue to progress? Yes. So they might need further surgery in the future. So again, that's something we counsel our patients on prior to the initial surgery. They say, hey, if it doesn't work for you or if enough time passes, you may need further surgery, okay? So what do you do? So we already know about the math that we do in orthopedics, right? 4 plus 4, 6 plus 6, things like that. Everything is 2, 4, 6, 3, 6, 12. That's it. There's no 11, right? We don't do things in those numbers. So you see somebody, you've been seeing them for a while, just say 3 to 6 months. You gave them home exercise program, you send them physical therapy. They really got no improvement. They continue describing all this snapping of the hip, okay, and or labral pathology, okay? You send them to someone like me, right? Do you think you might want to consider doing an MRI orthogram before you send them? Maybe, right? Maybe you should, right? But at least you would document, you know, consider doing this, but due to restrictions or what have you, depending on where you are, you know, that way it just lets the surgeon know, or the person that's reading the note know, hey, this guy or gal, right, worked up this patient, had a lot of different things, did an injection, like they did all the steps, right? They thought about the MRI because they know that when they come to see surgery, what are we going to get? The MRI with arthrogram, right? So that's just a way to think. And then all labral pathology, right? All. Because if you are even thinking to yourself, this is potentially surgical, just send it, right? Never decline that consult. So, because I just described to you that it may require a bigger move than just sending them downstairs or upstairs or sideways or whatever. You may have to send them to a whole different facility, okay? So you got to get that process started. Any questions about snapping hip syndrome? Nothing? Okay. We'll start this then. Transient osteoporosis of the hip. Well, are we still discussing topics that deal with adult patients? Yes. Oh, okay. All right.
So I just had a question as far as like MRIs and such, are specialties able to like get quicker typically?
So everybody, it's a good question. So I think your question is, right, and tell me if I'm wrong, I'm paraphrasing. Is it faster for someone such as myself to call radiology and get an MRI faster? Sooner?
I would assume, yeah.
Yes, it is. But we still run through the same thing, right? Because they'll tell you, hey, what makes you think that this patient needs the MRI sooner? Right? So it's not without challenge. Everybody likes a good challenge, right? And I look at the radiologist and I say, well, sir, I'm having a hard time seeing the labrum on X-ray. Right? Sometimes that works. Sometimes we're like, come on, really? Why? It's like, oh, well, this guy is due to deploy in 12 months, and we got to get this assessed, and we have to figure out what's going on with him, if he needs surgery or not, what physical therapy would benefit him. You see what I'm getting at? Sometimes you got to paint a picture, okay? So I will tell you that I have a special relationship with radiology. Whenever I get to a new base, I go down there and tell them, I am me, you are you. I introduce myself, and I said, I am the guy who will be hunting you down for emergent CT scans for interarticular fractures. I am the guy who's going to be saying, I need this MRI sooner, right? But you got to save that card. You can't just pull it random willy-nilly, right? You got to save it. Makes sense? So if you get somewhere, sir, right, and you're like, man, I've been ordering a lot of MRIs. Maybe it's time for you to get up out of your chair, very comfortable chair, right, and go down and introduce yourself and say, hey, I know you probably know my name, right, because they'll know your name. Everybody gets on a roster eventually, right, and say, I'm the guy who's seeing all these infantry guys, right, and all these guys with all this labral pathology, for example, and just form that relationship. It might make your life a little easier. Did I sort of answer your question at some point?
Yes.
Okay. So when I was in Japan, I'll say this because it's relevant, in Misawa, I already explained to you guys, where did we get the MRIs done? Was it on base or off base in the local Japanese economy? Off base in the local Japanese economy, right? So I could tell them whatever the hell I wanted, right? And they would just be like, well, it's the Japanese, you would have availability when they have availability. But was I able to affect the stack? Everybody knows what I mean by the stack, right? The racket stack, right? Right, because the referral management department will manage them based on when the referral comes in. So I would call them and say, I know you have a rack and stack, but I need this patient specifically to go up to this level of consideration. Make sense? Okay. Because it took me, by the time I left there, it was taking 4 to 6 months to get an MRI. That's me being orthopedics. That's craziness, right? So, because a lot of times, depending on what it was, for a lot of things actually, for example, ACL, right? If someone has a primary ACL, we can do it. Primary meaning first time they tore it, okay? If they had an ACL reconstruction already and sustained another ACL injury, now they need a revision ACL surgery, right? We couldn't do those there. So I had to answer that question sooner. Sir?
If the MRI takes that long, you need sooner in the facility can't go to well. How difficult is it to get TRICARE to MRI that?
Good question. But at least by loading, so his question was, it's going to take forever to get done on base. How quick is it to get TRICARE to approve it? Has anybody here ever dealt with an insurance company? Okay. Yeah. So the answer is variable, correct? Is TRICARE just one big insurance company? Yes. Right. So I will answer your question like this. It depends on where you are. If you're in Southern California, right, San Diego area, right, get set off base pretty quick. If you're in Kansas, right, we ain't in Kansas no more, right? Maybe the patient has to drive a couple hours, correct? So it just depends on where you are. I can't answer that question. I can't be specific. Make sense? All right. Transient osteoporosis of the hip. So again, getting back to what I was saying earlier, we're talking about adult conditions, right? Osteoporosis. Whenever you're thinking about osteoporosis, for the most part, you're thinking about adults. Okay? But this is transient osteoporosis of the hip. So transient meaning what? It's coming, but it should be going as well, correct? So, and the timing of it is very important then. We understand that already. So, this is idiopathic condition. It's radiographic evidence of osteoporosis of the femoral head and or neck. Okay? So we already understand that osteoporosis is decreased mineral bone density, correct? Remember we discussed that there's 2 different kinds? Is this the other kind? It's not primary osteoporosis, correct? Okay, so this is when that other category. Okay, so we finally found one that we're going to discuss in detail. Okay, does everybody see this picture here? How it shows this is what it should look like. That matrix should be nice and robust there. That density should be nice and robust. Okay, and when you go down to that bottom picture, right, you have a lot of decrease in that density there. Therefore, you have weakened bones, okay? Does this put whatever patient at risk for fracture? Absolutely 100%. Fractures of the femoral neck, especially, okay? But what is it most common in? Middle-aged men, okay? I think we're gonna have to start redefining what middle-aged means based on the fact that people live forever now, okay? But middle-aged men to me means somewhere 35 and above. So into your 40s, okay? That's what it means to me. Yeah. Well, I don't make the rules, sir. All right? Hopefully this one isn't offended. And also the third trimester of pregnancy. Okay? Third trimester of pregnancy. Okay? What is the average life expectancy now? Somebody know?
87.
God, there's a bunch of numbers. But whatever number you throw at me, 40 something, it sounds about right. So to me, it's 35 to like 45 range normally. Okay? I kind of think of it in those terms. Okay? How often am I going to see this in orthopedics? The answer is not very often. Okay? Because if properly managed, this can be managed with perfect care. Okay? Is there any surgery to do if you're just managing it and there's no fractures? No. Okay, but it depends. So, well, what's the rule though? Spontaneous resolution after 6 to 12 months of onset. Okay? And this is an important concept. This is onset, not diagnosis, correct? Okay? You understand? Okay, so patients have symptoms for 3 months. You gotta count that 3 months too. Okay? Makes sense? Okay, and that's an average. But just like we discussed with another condition, this can take some time to resolve. So you never want to tell the patient, if you just do what I ask you to do, you'll be better in like 3 months. Right? They'll be back in 3 months. And they'll be like, hey, I'm still not better. Right? So what's the number here? 6 to 12. Fits that ortho real nicely, doesn't it? Is it kind of similar to adhesive capsulitis? Yes, it's another one of those things where people are not going to necessarily get better in a quick and predictable fashion. Okay, so clinical symptoms, this is what you're going to discern from your history, taking a really good history. There was no related trauma. It was just a spontaneous onset of this pain in their hip. Make sense? Okay, are they going to describe pain worse with weight bearing, better with rest? Yes. Okay? So they're going to describe that, especially if they present later, they're going to describe to you that they had pain more so initially, and then as it went on, it seemed to improve. Does osteonecrosis of the femoral head follow that rule? No. Okay. So start keying in on some of that stuff. That's why I put that in bold gold. Okay. Non-specific locational, again, inguinal line, lateral hip or buttocks. There's the word antalgic gait again. Okay. Might this be a Trendelenburg style gait? Maybe. Okay. Maybe. So it depends on what kind of pimp walk they're doing. Right. But they'll have pains and extremes of range of motion. We've already described that when you put the hip in extremes of range of motion, that you are engaging the femoral head and neck region, correct? We know this. So that's basically what you're reproducing. And again, I told you already, when somebody calls me on the phone and says, hey, I can't do an exam on this 45-year-old male because he just has too much pain, I say, challenge accepted. I'll be right there, right? And I'm going to put him through it because I got to figure out what's going on here. So do you think we lean a lot on our radiographs and our MRIs to discern whether or not this is osteonecrosis versus transient osteoporosis on the femoral head neck? Yes. Okay. So what you're going to see is, again, that's why I introduced that term, diffuse osteoporosis of the femoral head neck, right? So it doesn't look like you have findings that are consistent with osteonecrosis. It just looks like you have decreased bone mineral density. That's the difference, okay? That's what you're looking for. And again, it may not be evident early on. Everybody sees, let me use this one. Everybody sees how nice, thick bone density seems there. And then if you go over here, it just looks kind of gray. Okay, again, it looks nice and thick, white. And over here, it looks a little gray. Okay, so that's an area of diffuse osteoporosis of the femoral head. That's what that arrow is delineating there. Okay? And then what is the confirmatory? Well, how do you discern that from osteonecrosis? That's basically what we're asking, right? Is you get an MRI, okay? And you look for bone marrow edema. Bless you. Okay, bone marrow edema versus what? What's the rule for osteonecrosis? Collapse. Correct? We have a collapse. Okay. It just looks different. There's more to it than just that. There's some examples there, again, of the area, the osteoporosis. But also down here, you see the femoral head bone edema? That's a white signal there, okay? White signal there. That's what we're talking about, okay? So I know that you're like, that doesn't make sense to me, right? Because you guys already know that MRIs are weighted, correct? You have T1 images, you have T2 images. So you have to look at the correct presentation as far as the image modality that was used and interpretation, okay? Good to go? Any questions about the diagnostics? Okay, let's take a break.
Thank you, by the way.
Yeah. Oh, it's a good MRI, like, you'll have capacity that you did earlier, then you test it up and they can figure it out. And honestly, it's going to be where you're at and what the protocols are. Like, Yep. So it's typically starts after puberty. So after puberty, and it's mostly gonna be female. So they're gonna have issues with mental psychoserturism, acne, substance use. Yeah. It could be you can see that basically like where usually just basically adult waste being like just not the right. It seems like meaning that they can't hold on. So they might be they can't hold it at home, then kind of attribute like it might not happen. They just can't. So we say if you see them like we just pay the crowd. And she's got to worry about the treatment for the master. Yeah, so like for non-classics, for PCOS, you usually go for backbone and OCPs. With the other one, you would just steroids. But yeah, just for her, she doesn't care about identifying it. I'm like, God, I'm sweating so much. I'm plugging my computer. Wretched. Yeah, I mean, I think what will get you is if you just don't read it right, or you just forget what is initial and what is definitive. Yeah, labs and stuff. So it's like just knowing at what point you do thyroid, like at what point should you do an FNA first before you do like a scan, or even a scan even viable, stuff like that. Like, just don't confuse yourself, and you should be fine. I mean, it's just like I just need to see how she tests. Like, until I see how you test, I don't know. And it sucks when like I only have 2 chances to figure it out. Yeah, like if her saying that like that's not the one that people see is cool, I'm not worried about that.
There's 50 questions. Why does it get identified? Why does it get lab? And then treatment. I think like those 3 things you know about. Like treatment.
Yeah.
I think if you can get those three,
So mine said 25 minutes. The rest of the time is like 7
It's primary. Yeah, primary is your
the
average.
secondary doesn't have.
And why does it have hypertrophy?
Yeah, because there's no, it's low.
Yes, ACT is usually like the mental stage, where you get the hyperpigmentation versus secondary, you get that alabaster skin.
I look. It says Towler, and I was like, Towler and Alabaster, I had to look it up.
You know what's funny? You know, one reason why I kind of remember this? There's an episode of King of the Hill where the little kid that comes down from Oklahoma is an alabaster jones, and he's voiced by Snoop Dogg, but he's like the whitest now. That's the reason why I remember that, because like, he's white, so.
We're not trying to
Alabaster
It
jones.
says Towler?
They were so cheap.
They are. I think they still are now.
Yeah, Pally. Some of those use like Pally.
It's a Towler.
Bless you, sir.
But I think of primary.
Thank you.
What?
I think of primary.
Yeah, that's cool.
Favor return.
Oh, that's not bad.
Oh, we're playing tattoos. You're more than welcome to join, sir. I have cats.
I wish tomorrow was at least something to review if it's not.
Yeah, I don't think we're going to go past that one. I mean, the last one did. That's all because kind of wasted time. If you just do like normal questions and ask like what we did last time, which should only go hard. Hopefully. Only now we're going to do too much.
I spent 6 years of my life doing it.
You know, if you vote tomorrow on the test, I'm gonna ask you what is the week 5?
I mean, that's the board if you want to.
Yeah, even if you can't move what it actually is week 5. Not 5. If that's where you want to.
Yeah, that's the review.
Well, Julie and I are going to
And then I can play for
Well, there goes the
Well, you know, one of the practice you're trying to get out second. The important thing is being able to write down like your main. And then like, for me, it's gonna be
The thing is, like, if I can hit on my computer, because as long as I'm actually attacking what's there, that's all I care about. Yeah, come on.
come with the emergency
Yeah, but
But again, all right, let's go back to my
so for
I don't care. That's why I don't.
I thought about it. I thought it was
What do you
I think Because what's it do? Hey, Lisa. I want to do you a favor.
All right. Settle it. Okay. All right. Are you guys getting picking up what I'm putting down when it comes to all this imaging and diagnostics? How are you going to figure things out? I hope so, because I'm really taking my time with this topic. Because hip pathology is something that's going to, it looks like it makes sense to you, right? I'm talking to you about it, and you're like, oh, that makes sense. Put the book away, put a question in front of you on a Friday about 0801, right? You're like, oh, this could be anything. All right, so you got to figure out a way how you're going to put this in your mind and discern what's what, okay? Makes sense? So if an MRI finding says that the area is concerning for diffuse osteoporosis versus diffuse osteonecrosis, right? You got to understand what that means. Good to go? Okay. Crescent sign, does that go with diffuse osteoporosis? Necrosis, osteonecrosis there. Yes. Okay. So study that way. Okay. So reverse outcomes of disease, right? So even if you kind of like say, well, we're going to watch it, right? Could they sustain a femoral neck fracture? Yes. That's the risk, especially in what age population? Higher risk in pregnancy. Unless you're saying that men could get pregnant now. There's been movies about it. Right? But the higher risk is in pregnancy. Okay? So again, if they give you a male, none of the male choices are correct. It's the higher risk in pregnancy. So it's going to be a female. You should be looking for in that answer set. Okay? Make sense? I know Mr. Frazier. We're not there yet. Okay? AI has not gotten us there yet. But there's hope. Okay? Non-operative. So this is transient osteoporosis of the hip. So like I started the topic, I told you, I said this comes, but it should go. Right? As long as you do what's right, it should go. Right? Otherwise, healthy person. Okay? So again, here's that nice little orthopedic rule, right? 6 to 12 months. Spontaneous resolution. Was it spontaneous onset? Yes. So spontaneous resolution, meaning pain one day, next day a little less pain, next day a little less pain, and they might plateau in their pain, right? And then all of a sudden they wake up one day out of the blue, they're like, oh, I feel no pain. That is spontaneous, right? So does that mean it's predictable? No. In this case, the answer is no. Okay. So acetaminophen, right? So there's been some controversy about that, but it's still in the literature. Okay. So it's still being taught. But acetaminophen may not necessarily be without risk for pregnant women. Okay. In pregnancy, I should say. Okay. But it's still in textbooks. Right? We know the textbooks are about 6 to 7 years behind, correct? So yeah, it's still in the literature. So it's still possible to see it on hands. So, and it says right to modification physical therapy. Sure, we know that that's kind of the Ortho thing, right? Crutches with limited weight bearing. Okay, we talked about. I kind of like told you what limited weight bearing was yesterday, right? You tell the patient, use these crutches. You can walk, but you're only that looks good. You're only putting 50% of your weight down on that side. That's limited weight bearing. Does that make sense? You got to tell the patient in some terms, some way, shape, or form, that they'll explain. Okay? Does limited weight bearing mean that they're going to be doing high impact activity? Negative. Does that mean they're going to be doing halos, hay-hos, and all the hose? No. You gotta look at their job and figure out what they can't do. Okay? Other men are out there in the 40s jumping? Absolutely 1,000%. Right? We love those people because they eventually come see us sometimes. Right? First group. All right, crutches with limited weight bearing until normal bone density on what? Is it an MRI? No. It is repeat radiographs. I already explained this concept to you guys. Even if you get a CT scan to help you with your diagnosis, right? Are you gonna keep repeating a CT scan? No, you're gonna repeat the radiographs and look for those changes. Usually in what interval? This is not testable. 4 to 6 weeks. Okay, because you won't see changes necessarily in an interval shorter than that. No significant changes. Make sense? There you go. Not testable. Just if you're pimped in phase 2, you got the answer. You were given it, right? So, all right. So referral decisions, right? What does it say there? Discuss choice of imaging and analgesics with patient's OB provider. That's if they're pregnant, correct? So this is something I've never discussed with an OB provider, right? But they'll discuss it with you. So, because they want you to know that they know what you know and what they should know and what you should do. Makes sense? So if there's ever any question about a pregnant female, right? Pregnant patient, right? And you're like, I don't know if your OB provider would approve of this treatment, you can discuss it with them. Good to go? I will tell you that, again, I have already admitted to you, I've never seen this in practice, but if you have a concern for a femoral neck fracture, okay, then you need to refer that patient for evaluation, okay? What are you gonna do, sir?
So would you do a DEXA scan?
That's a good question. I had somebody ask me that last semester. Again, I will full-heartedly admit to you guys, again, I've never really seen this in practice, okay? Because it's something you learn about, we never really see, right? Maybe they see us, but we don't see them, right? You've heard that saying, right? His question was, should we get a DEXA scan? I would tell you this, it's transient, right? So we kind of decide where it's at, right? Do we use our imaging studies to guide our treatment? We do. Okay, so I would say that if you look at it, and you decide for yourself it's not osteonecrosis, right? Can you get a CT scan on a pregnant person? Depends on who you ask, right? So the risks, the benefits have to outweigh the risks, right? But can you get an MRI in a pregnant person? Yeah, so there's still another imaging modality you can do that can give you more information, right? So having said that, I don't know that a DEXA scan will necessarily help you make a treatment decision. Okay? Would you be wrong in ordering it? I don't know the answer to that. I'll look it up. I'll get back to you. Okay? Good question. I was asked that before. Nobody really cared. They just asked the question, right? So I got back to them. But if you care, I will get back to you, sir. Okay? Because again, I've never worked this up. So for a pregnant female. For males, yes. Pregnant females, negative. Okay? How do you know that there's a concern for femoral neck fracture, impending femoral neck fracture? How do you know on clinical exam? All right. Pregnancy has its own gait, correct? Nobody got mad. Okay. Right? So they're out walking, right? And all of a sudden they're telling you they're pain, everything, it hurts, right? But now all of a sudden they're going 5 out of 10, right? And then a couple of days later, 6 out of 10. Then a couple of days, 7 out of 10. And then he presents you and saying now they're limping towards the end of the day. Does that sound like maybe a concern for a femoral neck fracture, impending femoral neck fracture? So what are you going to do? This is the big question. Do you ever want to willingly, or just willy-nilly, I should say, put a pregnant female on crutches? You got a whole nother set of issues, right? If they fall, oh my goodness, right? So again, you got to make a decision based on your clinical suspicion. Okay? When you put a pregnant female in a wheelchair though until they're seen by ortho, again, that's a decision. Okay? I can't tell you how to make that decision, but just be careful with that. Okay? Has anybody here ever used crutches? Okay, so you know that crutches, it's got that rubber tip, right? Is that rubber tip going to be more or less slippery when wet? More. Okay? Is that rubber tip going to be more or less slippery in snow and ice? More. Okay, there's actually an attachment you put on crutches. Everybody's been stationed in cold weather, seen it? A little attachment you put on there. Basically, there's a little point on it that digs into the snow or the ice. Okay? So again, if you're going to do it, you got to make decisions based on where you're stationed as well. Okay? Enough on that. Trochanteric bursitis. Any questions about osteoporosis of the hip before we move on? No? Okay. So when we talk about trochanteric bursitis, we're talking about that anatomy again, right? Is that lateral, anterior, or posterior hip pain? Lateral, correct. So greater trochanteric bursa, there it is, okay? This is not the greater trochanteric bursa. This is the greater trochanteric bursa, or just called trochanteric bursa, okay? It's red, it might be a little angry, right? So when they point, where are they gonna point? At the greater trochanter. Can they radiate a little bit distally as well? Yes. Well, their point of maximal tenderness will almost always, in my experience, be a point right over the greater trochanter. Can everybody find the greater trochanter on themselves? Okay, so that's where you're gonna put your finger. Right? You're gonna say, is this where it hurts the most? And they're gonna jump. And then you're gonna have a higher suspicion of greater trochanteric bursitis. Is that a test? That's on a few slides from now. So what are the causes? Well, idiopathic, we don't know. Right? That's what that means. Lumbar spine disease? Sure. Okay, maybe, right? Intra-articular pathology, because we already discussed this. If somebody has intra-articular pathology, for example, FAI or labral tears, can they also have trochanteric bursitis? Yes. Are those treated separately and differently? Yes. Okay, so it's important to be able to get a good exam and figure it out. Limb length, right? Leg length discrepancies. Okay, if you have somebody who has one side shorter than the other, right? Do they walk different? Do they have an antalgic gait sometimes? Absolutely. So those stressors in that area can cause them to have this trochanteric bursitis. And then if you have prior surgery throughout the area, you can have scarring, right? So buildup of tissue that wasn't previously there. And therefore, they develop that bursitis because is it causing impingement or friction there? Yes, that's what they're describing to you. Okay, the list is long, but again, distinguished. Okay, so just understand which one's in yellow. Gold, 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 gold. Inflammatory arthritis. What is that? What is inflammatory arthritis? I told you already. Is osteoarthritis, excuse me, considered inflammatory arthritis? No. Does you have inflammation in osteoarthritis? So, yes, right? But for classification purposes, if you're a budding rheumatologist, rheumatology PA, right? You will understand, right? Someone say who? No? Okay. So, all right, good luck to that. All right, so if you see something, a question on a test, and it's trying to trick you, right? Because that's a very commonly misunderstood concept. So what they're talking about here is rheumatoid arthritis, correct? So what percentage of rheumatoid arthritis type patients get referred to me for trochanteric bursa injections? A lot. Okay, so it does tend to coexist in that area. Okay, makes sense? And if you think way back, right, many eons ago in a galaxy far away, when we talked about rheumatoid arthritis, I told you they could have systemic or other body parts affected, and then bursas were prone to being affected. Okay, there you go. All right, so this is the one that trips people up. This is trochanteric pain syndrome. So I told you already, if you have a point and the only area that have pain is the greater trochanter, good to go. That's trochanteric bursitis. But if they have associated IT band, right, iliotibial band syndrome, can that be that snapping hip syndrome that we talked about? Yes. If they have associated gluteus medius or minimus pathology, right, we talked about that antalgic gait, that Trendelenburg gait, that Trendelenburg sign, etc. They can live here too. But so basically, when you're talking about GTPS, greater trochanteric pain syndrome, you're talking about you don't just have point tenderness of the greater trochanter, you have other manifestations as well. So let me ask you a question. I already told you when you think about hip pain, you think in terms of lateral, anterior, and posterior, correct? So in this case, will the patient or the presentation on the vignette on pants tell you that they have not only lateral pain, but also manifestations in the posterior or anterior aspect? Yes. So that's how you read that question, right? To discern what they're getting at. Is this GTPS or is this straight trochanteric bursitis? Okay, here you go. Any questions about that? I know we're all allergic to something. It's probably iPad. So when we talk about clinical symptoms, right? Lateral pain, there it is, question mark to the knees. Okay, so again, when you talk to a patient, you say, where does it hurt you the most, they might actually tell you to have knee pain as well. Okay, and then you gotta decide, is that, again, intra-articular knee pain, which we'll get to. All right, I get excited with that. But you gotta decide where, okay? Trochanter bursa, right, or gluteus medius and minimus, okay? This again gets to that seated motion. We talked about how this is the case, right? When you go from a seated to a standing position and vice versa, right? You either accelerate or decelerate, okay, to get into the standing or the seated position. You put that IT band stretch across and over the trochanter, right? So you're going to ask them, do they have pain with that first motion? Okay, and it lessens after a few steps. Okay, so they go from a seated to a standing position, they have that pain, then they start walking, and it seems to get better. That's what they're saying. Good to go with that definition? Okay. And then also with overuse, right? You guys know that overuse is something where, for example, in this case, we're talking about greater than 30 minutes of exercise. Okay? Because are they constantly snapping that IT band potentially over the trochanter? Yes. So that's what we're getting at. That's that friction that we talked about. Make sense? Snack, crackle, pop. That's what he's doing that back there. So night pain from laying on their side. Bless you again. Yes. Yes. I'm bringing meds for everybody. So night pain from laying on their side. Okay, so if you compress a bursa, do you think that makes the bursa angry? Yes. Bursa don't like to be compressed. All right, so if they lay on that side, what might you tell them to not do? Don't lay on that side. Okay, all right. So when we get to our physical exam, again, this is really where it's kind of like, I think it's intuitive, but I think what throws people off is the GTPS component. Trochanteric bursitis, they get it. But how is GTPS different? We will learn this before the test for sure. Okay. So with trochanteric bursitis specifically, you're going to do what's called the trochanter palpation test. You see that picture up there? The gentleman is palpating directly over the troch, okay? And they're pushing down, okay? And they're saying, is this where you have your pain? They say yes. Okay, good to go. You have a positive finding. They have pain overlying the trochanteric bursa with pressure or deep palpation, okay? Pain with resisted hip abduction. Well, you already have them in that position, correct? So you have them basically abduct against you, and that also reproduces their pain. Does that part make sense? Okay. Abduction meaning away, right? You have them on their side. In this picture here, represented, which side is symptomatic?
In the top picture?
The left side, correct? Because the left side is up. Does that make sense? The right side is down. Okay, good to go. So incidentally, do you think that's a position that if you get trained and you're good, that's the position you're going to put the patient in to do the injection? If you decide to do a corticosteroid injection? Yes. If you read in your textbook, it describes and outlines exactly how you do it, and that's how you do it. Okay. You put the affected side up. Make sense? Yeah. You can't put the needle to the bottom of the table, right? Good. You can try. Anyways, so favor test, you guys already know what this is, right? So now, are they laying on their side still? No, they're supine, correct? You put them in the figure 4, otherwise known as the Patrick test, probably has 1,000 other things, right? But you do the favor test, and they have pain in that area too, okay? Oh, we just added a positive finding for a favor test. So hopefully you guys have learned from me by now, right? I hope, that when it comes to all these tests, you can't just say positive, right? Because you can have a positive finding with a favor test, both anterior hip, posterior spine, or posterior hip, right? And what is it now? Right? That have pain that's reproduced over the trochanteric region, the lateral hip region. Make sense? So a positive test, when you document it, doesn't mean anything to me. I don't know what you're saying. But if you put positive for reproduces pain on the lateral hip overlying the trochanter, I get it. That's what you're telling me. Does that make sense? You're telling me something. You're speaking to. Okay, so GTPS. Okay, so GTPS, well, that means that you have gluteus minimus medius pathology as well. And you're going to have an IT band involvement too, right? So do you think you're going to do all those tests for IT band and for gluteus medius and minimus weakness? Yes. What is the gluteus medius minimus testing? That's that Trendelenburg. test, right? Looking for that Trendelenburg sign. Okay, makes sense? So we'll go through all that. You see how hip pain can be not straightforward. So Trendelenburg test. This is every semester, right? This is the topic I was telling you guys. I allegedly added this slide, right? So when you have the patient stand, for in this example, what? On the left leg, and the right hip drops, which the test is positive, correct? But for which side?
Left side.
Who thinks left? It's the majority. I won't call other people out. But it's testing for the stance side. So I already explained to you the stance side, correct? You guys know what a stance is now. I told you yesterday, right? So it's the stance leg, not the leg that's being lifted. So the correct answer here is left-sided gluteus medius minimus weakness. Okay? Who disagrees? Scaredy cats. All right. But I will ask that question. Can I ask that question like 3 different ways? Yes. So make sure you understand that concept. And we'll go through it live, okay? You might be the class that gets it finally. We'll find out. Okay. So, bursa, okay? So why do we get radiographs? It's all soft tissue, Major Davos. It's tendon, it's bursas. You're not going to see anything on x-rays. Well, as this x-ray shows you, got a bunch of white arrows, right? There's something there, right? So if there's areas where they have prolonged and sustained inflammation, can it cause bony reactive changes? Yes. We already talked about rheumatoid arthritis, correct? Who hates you? You. So therefore, your body's trying to destroy you, correct? So you could have erosive changes in that area. Make sense? What might the treatment change in that case? The answer is always yes. So you want to rule out bony abnormalities and or intra-articular hip pathology, right? When it comes to trochanteric bursitis, though, it kind of quacks like a duck, right? Sounds like a duck, walks like a duck, no pun intended, right? Then it's a duck, right? So we don't commonly get MRIs, right? So, so it says here rarely needed, right? But if you have a concern for an occult fracture, tumors, there it is, AVN of the femoral head, all right? Did we say the osteonecrosis of the hip? Because sometimes the patient has pain, right, in the hip, but it refers to the lateral or the buttock region. Yes, we said that, right? So is the lateral region the greater trochanter? Yes. So maybe an MRI in that case, but rarely needed just for primary diagnosis. If, again, your strong diagnosis is trochanteric bursitis. So can we do an injection that's both diagnostic and therapeutic? Yes. So then you do your injection, patient gets pain relief, and you're like, okay, it was the bursa. Move on. No MRI needed. That's the example I'm giving. Okay? First, adverse outcomes of the disease, chronic pain, obviously a limp. Okay? If somebody's sleeping on that side, it's painful, or if they have pain more so towards the end of the day, right? Because they also have associated GTPS, then they can have sleep disturbances. Okay? Makes sense? Okay? So what is an on-op treatment? You see that picture there? I like this picture. Okay? See that there? I allegedly found a picture that the provider was actually wearing gloves. Right? But because you never want to do injections without gloves on, correct? Right. So, but this picture also shows you the anatomy. Okay? You can feel your greater trochanter. Right? Find it on yourself, and next week you'll find it on each other appropriately. Okay? So apparently we're getting tattoos at some point, so maybe you'll find it sooner, but whatever. All right. So when it comes to greater trochanteric bursitis, though, you're going to say, where does it hurt you the most? And where do you put the needle? Where it hurts the most. And I say, here we go. Right? And so, do you think that for the average person, right? I'm not exactly Mr. Big Thighs, right? Big hips. For the average person, you can get there pretty quick. Feel your greater trochanteric bursa. You get there pretty quick, right? So there's a general rule. You're just going to stick the needle until you find bone. Pull it back about 1 to 2 millimeters and start injecting. They're going to feel the burn. Should they feel neural pain? No. If they feel sharp, nerve-like pain, stop. You are in the wrong place. Okay? You're probably too medial. Right? That's why you want to put them in the lateral decubitus position with the infected side up. You you think there's a reason I'm telling you this? Yes, because of some phase 2 issues recently. Okay, so there you go. You're welcome. So NSAIDs, rights, activity modification, that's your first step. Physical therapy always, right? What are they going to do? So remember I told you, when you send someone to physical therapy, don't just put physical therapy, hip pain, right? Tell the therapist, I think this patient has trochanteric bursitis, and I want to do an injection yet. But I would like you to do IT band stretching, and hip abduction strengthening, right? That's what you put in your console. Is it in bold gold? Yes, because that's what you want to do, okay? And then, if all else fails, you can consider a bursa injection, okay? When it comes to rheumatoid arthritis, do you think they're being referred to me when they have a lot of pain? Yes. Okay, so usually we do the injection first visit. Does that make sense? All right. Yeah. But when it comes to most other cases, I already told you this concept. If someone comes and says, this hurts, and you say, I'm going to inject you today and send you to physical therapy, what do you think the compliance rate is with that kind of approach? Not very high, because about 24 to 72 hours later, they're going to feel, okay, sir? They're going to feel less pain, right? And they're going to be like, I don't need to go to physical therapy. I'm fine, right? And then they're going to come back when that injection wears off. Does that make sense? So it's not necessarily a go-to for me. Okay, good to go? Okay. All right, but you'll decide in your practice how you do it. Okay, just trying to give you some guidelines. And if they return and they say they've been doing their physical therapy, right, their home exercise program, right, the patient advisor, right, how do you confirm whether or not they've actually been doing their exercises? Show me your exercises. If they go, or even pause for a second, right? What is it, Mr. Shea? All patients lie, right? So there you go. So then, do you reward them with an injection? Depends on how you practice, okay? Operative, rare. Okay, rare. What's the only choice if the bursa is angry? Take it out. It's a bursectomy, right? Will they still potentially have issues? Now they don't have a bursa that's causing less friction, correct? It's buffing that friction. Okay, so might they have other issues in the future or just continue pain? Yes. So again, it's not rare. It's not common, excuse me, it's rare. Okay? So the bursectomy. Okay? Risks, again, NSAIDs, right? And infection risk from injection. Okay? This is, like I said, a pretty superficial injection, so you know how you guys talk about and learn that you can have skin dimpling, right, or atrophy of the skin, fat pad, or you can have some color changes there. If they're darker skinned and you inject there, it's pretty superficial, right? Why they have some lightening of the skin in that area? Yes. Okay, so this you may see it in this kind of injection too. Same as lateral condylitis. Okay. So when are you going to refer? You're going to do all those things in those numbers we talked about, the 3 to 6 months, etc., plus or minus the injection, right? If the injections aren't working, do you keep doing them? Nope. So treatment failure, send them. Diagnostic uncertainty, you're like, pretty sure this is just straight up trochanteric bursitis, but there may be a component to GTPS. Oh, and then, I don't know, I looked at the MRI, but I don't really know what I'm looking at, right? Oh, and it wasn't an orthogram, it was just an MRI, right? So the diagnosis is uncertain. So you send that as well, okay? Suspected fracture, that just makes sense, right? So it's a conclusion. We talked about hip impingement. We talked about all those anatomical landmarks, right, and all those the relevant anatomy. We talked about a cam deformity, right? That's the femoral head-neck junction. We talked about a pincer deformity, right? That is the acetabulum, and that's that overcoverage. Okay, we talked about how you can have those either acute onset of symptoms at a younger age, or you can have, you can have patients that present with a history of hip impingement that now has gotten worse. So you got to decide what spectrum you're in, right? And we've talked about what radiographic findings that you're looking for. Okay, gun stock, pistol stock deformity. What's that also known as? I think we're allergic to endo. That's also called a cam deformity, right? Or the bump, as some people say, the bump. Okay, all right. And pincer type. Can you have both kinds together? Yes. So don't fall for that. All right. Let me ask you a question. Okay, I just want to get to it. We're doing a review, right? So when we're talking about hip impingement, you're getting X-rays, correct? We're talking about getting hip x-rays, okay? Do you think sometimes you have to get dedicated views of the femoral head neck junction to get a better view if it's kind of a questionable cam deformity? The answer is always yes, correct? So somebody in here knows, I'm sure, that there are dedicated FAI series in Genesis, right? Depending on where you go, you can get dedicated views, right? So just keep that in the back of your mind, not testable, but do you want to see necessarily the hip joint itself, or do you want to see, again, the proximal femur better? Proximal femur. So therefore, with that logic, you already know this. This is not new information. Maybe a hip and a femur series will benefit you, right? So that's where the FAI series comes into play. Orthopedic surgeons created this series where they put the leg in a very specific manner to get a better view of that head-neck junction, not testable. Okay, but at bare bones, you know that you should get a femur series. Okay, makes sense? That's not new information. Snapping hip syndrome, internal, external. Okay, so if it's internal, what's the big trip up with internal? Labral tears. Okay, that's the one I see. People are like, I got it. Snapping hip. Is it though? Right? Is it the iliopsoas? Is it in and around the iliopectineal eminence? Or is it deep inside the groin, like the hip region? Therefore, it's more likely to be what? Labral pathology, right? So when you're studying, make sure you can pull that out. I think once we do, right, it's like a tissue. Pull it out. Tissue for your issue, right? So when you are studying, after we've done the lab, I think it'll make more sense. I'll teach you a test you can do to kind of like nailed it, right? Gives you a little more information. Not testable, but I'll teach you it. Transient osteoporosis of the hip. Mr. Deloach, who gets that? Pregnant women and pregnant men? No, wrong. Okay. It's funny, but it's wrong. 50-50, 80-20. So if you said 50, well, how long do people live? 80s, 90s, somewhere there. So 40s to 50s sounds reasonable. So that's not a bad way to think. Yeah, actually almost got in the ballpark there. All right. So remember, I told you the rule of orthopedics, 50-50, 80-20. When you want to practice, you're like, I get it now. I don't know why you kept saying that. Okay. All right. Anyways. So when you're looking at a scenario for transient osteoporosis of the hip, make sure you're looking into the fact that the patient has what? Spontaneous onset, correct? Does it get better or worse throughout the day? Okay. But how is that different than osteonecrosis of the hip? That's a question you have to answer for yourself. How are you going to remember that, right? Right? And then how do you add into that you may have radiographic findings? Okay. You guys have seen my questions, right? You know how I think. It's a scary place, right? Okay. But I usually won't get, so you're like, well, if you ask me a question like that, the initial question I just said, how the hell am I going to guess, right? Would I do that to you? Maybe one or two, right? But I'm just saying, that's a joke, for the record. So look at the radiographic findings and look at the physical exam findings. That's how you study these things. Make sense? Moving on. Trochanteric bursitis. What's the one area that everyone struggles with trochanteric bursitis? GTPS. Okay? Because it seems like I introduced GTPS now because it goes with trochanteric bursitis, obviously, is in the name, right? And then later on, we talk about Trendelenburg, and then you don't come back and put that together. Okay? So don't make that mistake. Good to go? Okay. A couple of options, sir. I know you're texting the next instructor by now. All right, so we can either push, right, or we can break now, and you guys will move on to your next course. What's that, Rich? Push? Okay, I like that. So, because this makes me super happy. Okay. Anterior cruciate ligament, bursitis of the knee, claudication. You guys have learned about vascular and neurologic claudication already, right? They keep sliding this into my lectures. I can't do anything about it because it kind of goes with MSK. But are we talking about neurogenic or vascular when it comes to ortho? Who knows, right? They could both exist. Collateral ligament tear, IT band syndrome, we'll get more into that, and gastrocnemius tears, okay? All right, so ACL tears, anterior cruciate ligament. We've decided that this is an intra-articular ligament, correct? Okay, so, well, have we decided what kind of patients get this injury? Not yet. I will teach you. I will teach you correctly, and you will never get this wrong, ever, okay? But backing up to the definition, the ACL provides primary restraint against anterior translation, and then also provides rotary stabilization as well. So everybody knows what rotary means, right? Rotational, okay? Right? So it assists in that area there, but it's a primary stabilizer against anterior translation. Bless you. So it's needed in agility sports, not straight line running, okay? So what that means basically is that's needed for cutting, right? Duke and dodging, cutting, twisting, turning, and what? Uneven ground. Make sense? Okay, so this is straight line running. That's like running on a track in a straight line. And if you're walking on uneven ground, does that cause rotational forces through your knee? Yes. Okay. So tears from a rotational force plus or minus hyperextension force. Okay? I need you to understand this concept now. When it comes to ACL, it's hyperextension force. When it comes to PCL, it's hyperflexion force. Right? And I will reinforce that when we get to PCL. But just understand that concept now. It's in the slide. Okay? So what happens? The person, right, the running back, what have you, they plant, they pivot, and they feel the pop. Okay? Was that a contact injury? No. Okay, so most ACL injuries are actually non-contact injuries. So what is the history going to tell you? They're going to say, I was doing XYZ activity, I planted my foot, I rotated, I felt a pop, and afterwards I was unable to continue with whatever activity I was doing. So do you think that's important to ask the patient as part of your history? 100%. That is your classic ACL injury. Is that the only way people get ACL injuries? No, I'm not saying that. But the classic ACL injury pattern, mechanism, if you will, is a non-contact plant, pivot, pop, and inability to continue activity. Okay? So if they're able to continue activity, do you think you might consider other pathologies? Yes. Okay, that's what I'm getting at. Okay, so which kind is more common? Complete or partial? Complete is more common. Okay, do partial ACL tears occur? Yes. But the more common is the complete, right? What grade is the complete? It's a ligament, correct? Ooh, I'm making you go back. All right. Grade 3, right, Mr. Dick? Yes. He's smiling because he knows, right? So that's a grade 3, a complete tear or a rupture. You guys understand still, right, that is the same thing. Okay, don't let that terminology throw you off. Okay, bear with me. ACL can be exciting if you let it be. Okay. All right. So what is associated with ACL injuries? In acute injuries, it is medial meniscus tears. In chronic ACL injuries, it is lateral meniscus tears. So what does that mean? Do patients that have chronic tears tend to be more partial? They go on to be worse? Yes, right? Just by definition, though. Is that how every single patient presents? Negative, right? I know someone's going to go do it every semester. Someone does the Google search, and they find an article that says something different. Look for the key words. When they're talking about those patient populations that they're in those studies, are they talking about patients that sustain an injury within weeks to a month? Or are they talking about patients that have chronic injuries? Okay, don't fall for that trap. Okay? What else is associated with it? Medial collateral ligament injuries, okay, MCL injuries. Okay? So it's a rotation, correct? It's a plant, pivot, and pop. Okay? The MCL is most commonly stressed in those type of motions and those type of forces. Okay? Less common is the lateral ligamentous complex or PCL tear. Okay? What is the lateral ligamentous complex? That is not the same thing as the LCL. There's a lot there. There's a lot of structures in that, okay? Lateral ligamentous complex is very complicated, okay? So I will tell you that there's a bunch of tests that I will not have the time to teach you, unfortunately, unless you ask. Okay, but the lateral ligamentous complex, right now, getting out of the way, it's not the same thing as the LCL. Okay? It's more than that. It's that posterior lateral complex. PLC. Right? Posterior lateral complex. PLC is not the same thing as PCL, correct? Okay? That's another thing I need you to understand. So as we progress in this, I'll try to clarify that, but I just want to bring it out and put it on point now. Okay? Multiligamentous injuries uncommon, but if present, gross instability is possible. And also a popliteal injury. Okay? We talked about this. If the injury pattern is so significant and maybe contact was involved, right? Because they can still get an ACL injury from contact. It's just not the most common pattern, right? What is the risk? What is the risk of the popliteal artery? A knee dislocation, correct? So by definition, think about this real quick. If you have multiligamentous, meaning the ACL, the PCL, that posterior lateral corner, plus or minus the MCL, which is more common, right? Well, you have gross instability. That's all they're saying. That's all they're saying. It's a multiligamentous injury. So is the surgery more involved? 100%, right? But the big thing to figure out is if the patient has initially, acutely, if they have any acute emergent condition present, such as a popliteal injury. Good to go? That's all they're saying there. Okay? All right, when it comes to ACL tears, clinical symptoms, sudden pain giving way to the knee due to twisting or hyperextension, and 1/3 report an audible pop. We talked about this before, right, with the biceps tendons, right, when they pop, right, that's why I use the term. Achilles tendon, that sounds like a gunshot blast in the back of their heel, the back of their ankle, right? So they report they heard it, okay? Unable to play, I put that in bold gold. They're unable to return to play, and they have plus or minus instability. Let's talk about this real quick. Why do you say plus or minus? Let me ask you a question. If you sustain an ACL injury, and somebody in here has, right? Right away, if you examine someone, if you run up to the field, right? I run up to this gentleman, right? And I do an exam right there, I'll feel that mass, right? If given enough time, the ligament tore, right? Is it going to bleed? Is that joint going to fill up with blood? Is that called a hemarthrosis? Okay, so then all that pressure is going to make your test less reliable, right? And we go less reliable because you have resistance there. Does that make sense? Yeah, the fluid is resisting. It's filling that compartment, otherwise known as the knee joint. Okay. Right? So what normally happens is the patient says they were unable to return. They come to you to see in clinic like a day or two later, and now that knee is big and swollen, bless you. Right? And you're like, ACL feels solid. Does it though? Is that a good time to test the ACL? Negative. Right? So you're going to send them physical therapy. They're going to do infusion therapy. That's basically get rid of the swelling. They're going to restore range of motion. You're going to see the patient back in a week or two, and there it is. There's that nice, what's that test called? Yes. You're like, you didn't fall for it. Don't be that PA. Don't fall for that pattern that is predictable. Makes sense? Okay. If they were unable to continue play, they have the classic findings. Right? You gotta get them into some therapy and see them back to do a better exam. Okay? Instability later as the patient returns to agility exercises. Okay, so that patient sustained the injury, they went to the therapy, they feel better, right? They're not really running, twisting, turning, but now they go back to activity, don't get seen by orthopedics, for example, or don't come back and see you, right? They return. Do you think they're going to have instability on uneven ground? Yes. Do you think they're going to have the inability to twist, turn, and cut like they used to be able to? Yes. Okay, so that's all that's saying. Okay. And chronic knee pain if untreated. Okay. Do you think ACL injuries are because of that instability that's created, both with anterior translation and rotary translation, that their meniscus will wear differently? Yes. Right. So it can cause, if untreated, it can cause all kinds of complications as far as further accelerated degeneration of the knee, right? Damage to the meniscus and or articular cartilage. Okay, good to go? So does that all make sense? Okay, so Lockman's test, okay? Lockman's test, right? So when you guys do your Lockman's test, how were you guys taught? With the patient laying on the table supine? Okay. Okay. Were you able to get a Lockman's test on every patient every time? And you felt good about it? You could feel that nice endpoint? Everybody knows what I mean by endpoint, right? Right? You're not just trying to see and feel if you can move it. You're trying to see and feel how far you can move it, and do you feel a nice endpoint compared to the other side. If you can't feel that, you are not doing it correctly. Make sense? So I'll teach you a couple of tricks in the lab, how you can do. It doesn't matter what size you are. Whoever in here is 4'8", 5'2", whatever, you can do an exam on somebody who's 6'5" and 230. Doesn't matter, right? Because this is not a strength thing. It's a technique thing. You got to put the knee in the proper position to be able to translate that knee anteriorly, correct? Is it the knee or the tibia? Tibia, right? Because our test is stabilizing with the proximal hand and trying to anteriorly translate it with the distal hand at the tibia, with your thumbs at the tibial plateau. That's how you guys were taught, correct? Sure, I like that answer better. Bunch of liars. All right. So anyways, so I will teach you that, okay? Because again, when it comes to the Lockmans, is that why is the Lockmans not called anterior posterior? Because you're not necessarily going anterior. Does that make sense? If you put the knee at 30 degrees, are you going anterior? Not always. Okay, you're going more up and back, right? So if you have the knee in this position, for example, I'm trying to put their knee this direction towards the corner of the room versus just straight up. Because when people think anterior, they think up. But you just put the knee at 30 degrees, correct? So you actually have to go anterior still. Does that make sense? So going up is not necessarily anterior if the knee is 30 degrees. If I haven't lost somebody, I'm just not trying hard enough. But what I'm trying to get at, right, that's a joke. But what I'm trying to get at is you're doing it, you're probably trying to muscle through it if you're not feeling that endpoint because you're not doing proper technique. Okay, so when you look at these pictures, you see how I just described that test to you? That's the way you should think about this test. Okay, good to go? So laxity with no solid endpoint indicates ACL tear. There it is, the word endpoint, right? You should always feel that endpoint, right? So you're documenting grade 2, 5 millimeters of translation compared to the contralateral side, but still with an endpoint. Does that make sense? Because if it says there's an endpoint, that means that the ligament's still intact. It doesn't become a grade 3 until it's not intact. Make sense? Okay, good. So there's more components to documentation and testing than just, oh, it moves. That's too easy, right? Anterior drawer test. Why is the anterior drawer test not the most sensitive and the Lockman's test is? It's because of, again, the principle I just discussed to you, where you're trying to put the knee in a position of disadvantage to see if there's actual instability. Okay? And when you put them into an anterior drawer test, like it tells you there are secondary stabilizers that can fool you. Make sense? So you should be decent at doing anterior drawer, but you should be really good at doing the Lockmans. Okay, because if you don't know how to do a good Lockmans, then you'll miss it a lot. Okay, which one's the most sensitive? Good. And pivot shift test. Every block, right? People are like, I'm like, I teach you how to do the pivot shift if you want to learn, right? I will not test you on it, but just know it exists. Okay, but does the pivot shift try to create anterior and rotary instability? Right, because the Lockmans and the anterior drawer, they don't create rotary instability, correct? So you're trying to introduce a component of rotary instability for the pivot shift test. But every semester someone tells me, I got it, sir, I got it, I nailed it, right? The reality of it is, most patients you cannot get a good pivot shift test. Why? Because they keep firing the quad, they won't relax, you can't get them to relax, right? So when do we get a good pivot shift test? In the operating room where they're asleep, right? Right, they're tiny whiteys, and you're like, and then everybody gets a turn. So scrub tech, the person has the phone, and like, come here. Feel this. This is a pivot shift test, right? And then you're feeling that rotary component to it. Make sense? So pivot shift test is important to understand that it plays a role here. But again, as it says there, it's difficult to perform because it requires complete relaxation. Right? When you give them the drugs, you get complete relaxation. Okay? So I want to stop there. Okay, and we'll continue pressing next week. Okay? Hey, good luck with your test.
Thank you.